In this section, we'll be discussing on crystal-induced arthritis. In the former section, we looked at arthritis, rheumatoid arthritis, and we've now to look at osteoarthritis. So in this section, we'll be focusing on crystal-induced arthritis. So in this section, we'll be looking at is as gout and pseudogout. That are the common causes of crystal-induced arthritis, or rather, we say they are the major crystal-induced arthritis. So let's briefly look at what a good joint, a healthy joint, how a healthy joint actually functions. Now look at this. This is a hip joint, and this is where arthritis, both osteoarthritis, do occur. Then this is the new joint. Also, osteoarthritis also occur here. Also, these induced crystal-induced arthritis also occur in this joint. So we're going to look at how a healthy joint performs before we move into the disease proper. Now look at how a healthy joint actually functions. See how it's moving freely without any hindrances. So someone will look at this, also see the joint moving very well without any hindrances. So this is how a healthy joint actually performs its function, moving freely without any hindrances. You see how it's moving very freely without any hindrance. And look at these structures, how healthy they are, very healthy. But in any of the disease states, when they become infected or destroyed due to degeneration, these articular surfaces are the ones that are being affected, which hinders this free movement you are seeing here. Now let's quickly look at parts of a joint and the functions each does, so that we would comprehend the likely challenges persons who have this any of these conditions might likely face. At first, looking at this structure here, this is a diagram of a perfect joint, and this has this the upper bone and the down bone, the upper bone and the down bone. This is the patella, the bone, but here is not, because we need to see this structure here. But the patella usually stays here. Okay. Now look at this is the articular cartilage. This is known as the articular cartilage. And what is the function of this articular cartilage? And we said that this articular cartilage, look at it here, covering the end of the bone. This articular cartilage is what you're seeing here, is a very important structure because it allows for smooth, slippery movements. It allows for free movement in the joint. So it allows smooth movement. If you recall from the video we last watched, you would see that this articular structure here allows for free and smooth and slippery movement here without any hindrances. Same if you look at here, you see how this is moving freely without any hindrances. Now, that's the first function of this articular cartilage. The next is that it helps in shock absorption. The articular cartilage helps absorb impact and distribute load during activities. This bone now you're seeing here, this articular helps in shock absorption, carrying the weight and all of that. Then it also supports the joints by maintaining its shape. If this wears off, then there will be a gap here. If this paraventure goes off, then there will be a gap. And once there is a gap, the stability of these joints is altered. So this articular cartilage you are seeing here contributes to maintaining the joint stability. That is why if you look at the video here, you will see how this is moving freely. It's because of this articular cartilage here, allowing to move and ensuring the stability. Let's say this wears off, this articular cartilage wears off, and this wears off. It will no longer fit very well. It will be wobbling. As such, it will lead to instability of the what? That joint. The next structure we're going to look at is the on the bursa. Yeah, the bursa is not signed here, but look at the bursa here. It is a small fluid field. It's a small fluid field structure. This you're seeing is the bursa. That is located between the bone and soft tissues. The soft tissue can be muscle, it can be tendon. So here it is found between the muscle and the bone and also the joint capsule. So it's fluid field. So it's like a cushion pad. Okay. So what does it do? It allows for free movement as well between the bones, tendons, and muscles. As the muscle contracts to draw this bone upward and downward, you would find out that if without this bursa being here in place, this muscle will be rubbing directly with these joint capsule and the bones, and that might affect movement. So that's why when a patient had this infection of the bursitis, the person feels an enormous pain and there's limitation in movement because of the effect. So the major function is to cushion pressure point. It cushions the pressure here from the muscle from not getting direct impact of the bone that is moving. Okay, and also it allows for free movement of the joint. The next we're looking at is the epiphysis. Epiphysis, this is the epiphysis. That is where the growth of bone do occur. After adolescence, this epiphysis growth stops. Okay, so it is the end segment of long bones, and they are covered by articular cartilage. That is, this cartilage you are seeing here covers this epiphysis. You can see they are covering the epiphysis, covering the epiphysis. What is the major function of this epiphysis? One, it contributes to load distribution. Like we said, without an articular cartilage, it does that. It also helps in joint stability. Think of when this bone is not here. This joint will definitely not be in place. So it contributes to joint stability. Then primarily for growth. So that is the function of the epiphysis, this epiphysis. Now the next is enthesis. Enthesis is just the site where the tendon or ligament attached to the bone. So wherever this is the ligament, the ligament attached to this bone is an enthesis. Then the tendon that connects muscle to the bone, wherever the tendon attached to the bone, is known as enthesis. So infection of this point is known as enthesitis. Okay, so that is the function of the enthesis. Enthesis also contributes in force transmission. If this muscle contracts to pull this bone to move, like we saw there, this muscle contracts, it pulls the tendon. The tendon, through the attachment at enthesis, draws the bone. So it helps in force transmission. Okay, it transfers force from the muscle to the bone. It also helps in structural stability. Let's say there is no enthesis. That means there will not be attachment of this tendon. And so this thing will not have any effect. This muscle will not have a point of attachment as such. The muscle cannot function. Even if it contracts, it cannot be able to pull the muscles. It cannot be able to pull the bone. As such, it cannot function very well. So it helps in structural stability and integrity. Then it also functions in shock absorption. It may help in cushioning the effect of what pressure. So that's the function of enthesis. Then let's look at the tendons. Like we say, tendons connect muscles to the bone. They are strong fibrous connective tissues that connect muscles to the bone. And their main function, like we said, is force transmission, stability, and they're also elastic and flexible, allowing for greater movement of the joint. The next is the joint capsule. This is the joint capsule. This is the joint. What encloses this joint is absent in this structure, in this photo here. It's what encloses this structure here. So the joint capsule is a fibrous structure that surrounds and encloses the joint. As you see, it encloses these joints here and also encloses these joints here. So what's the main function? It encapsulates the joint and helps retain synovial fluid in place. It does that. It helps to retain synovial fluid in place so that this synovial fluid does not leak away. No, this synovial fluid cushions the effect and lubricates these two surfaces here. It lubricates it and allows for easy movement of these joint. Then the synovial fluid proper, like we said, is a viscous fluid secreted by the synovial membrane that fills the space between the joint capsule. Its main function, like we said, is lubrication, and also it provides nutrients like oxygen and nutrients to the cartilages here. These cartilage surfaces do not have direct blood supply. The bone has blood supplies, but you see this cartilage, this articular surface here do not have direct blood supply. So it is through the synovial fluid that you receive this oxygen and nutrient for other function. So another thing is the ligament. Like you see, the ligament connects bones to bone. So the ligament is a strong band of connective tissue that connects bones to other bones at a joint. Their primary function is joint stability, like in other structures. It also supports movement. So these are the major functions of each part of the joint. And this is very, very important. We understand this because it's the basis. When you understand this, you now have a clearer idea of what do happen if someone has a problem. Now, what happens in crystal-induced arthritis is that these surfaces are being destroyed due to formation of crystals. They are now deposited here. You just imagine here, like smooth as it is here, and something like stones are now found forming here. It will definitely destroy this articular surface and lead to friction, pain, and all of that. So that's what like a patient who is having a crystal-induced arthritis do face. This smooth surface is being damaged by the crystals. Now let's look at crystal-induced arthritis. Crystal-induced arthritis is a form of inflammatory arthritis that arises due to deposition of crystals in the joints surrounding the tissue. This condition can be primarily classified into two main types based on the type of crystals that are found. We have the gout, which is caused by monosodium urate crystals. That is gout. You may have heard about gout arthritis. It is caused by deposition of monosodium urate crystals. We're going to know how this is been found and formed later in this section. Another type of crystal-induced arthritis is the pseudogouts, also known as calcium pyrophosphate dehydrate crystal deposition disease, CPPD. Pseudogout, also known as calcium pyrophosphate dehydrate crystal deposition disease. All of these are just crystals that have either of sodium urate crystal that leads to gout arthritis or calcium pyrophosphate crystals that leads to CPPD. And these are crystals. So when they are deposited, look at it, this joint is already infected. This particular joint is infected. So the type of crystal that is deposited here would tell us the type of crystal-induced arthritis that the patient is suffering from. If you look at look at the formal, the joint that is called that was very smooth here, as smooth as it is here, is now being destroyed because of the position of either monosodium urate crystals that leads to gout arthritis or calcium pyrophosphate crystal that leads to CPPD. And when this happens, it's C destructions. The smooth surface has been destroyed. And this is intracellular calcification. The epiphyseal plates, the epiphyseal articular surface is being destroyed. The articular cartilage is destroyed. And look at the urate crystals. And when you see urate crystals, we're talking about what? Gout arthritis. Look at the crystals are now forming, being deposited here. The capsule is destroyed. The synovial fluid is now leaking off. Then the synovium is destroyed, and a lot of masses are now forming. These joints will find difficult to move freely because the smooth integrity of the joint has been destroyed. And look at the erosion of the margins. The margins are now eroded, being destroyed, no longer smooth. So that is what typically happens in crystal-induced arthritis, either of monosodium urate crystal origin or calcium pyrophosphate dehydrate crystal deposition. So that is what happens in crystal-induced arthritis. Now let's look at the physiology of crystal-induced arthritis. How does this disease begin? At first, it starts with crystal formation and deposition, urate crystals. This, like we said, we have this disease is either pseudo gut or gut itself. So in the gut, there is an excess of uric acid. Uric acid, the excess of uric acid, also known as hyperuricemia. Hyperuricemia. And this hyperuricemia occurs when there is either overproduction of the uric acid in the body, one, for whatever reason. Two, could be as a result of reduced renal clearance. That is when the kidney is failing, the kidney is unable to remove the uric acid, or both. So gout arthritis do occur when there is high or excess of uric acid, primarily due to hyperuricemia induced by either overproduction of the uric acid or reduction in the ability of the kidney to remove excess uric acid from the body, or when both, like excessive production and reduced clearance from the body. When sodium urate levels surpass the solubility threshold, approximately 6.8 milligram per dl, then monosodium urate crystals can form and deposit the synovial joint. So this has to do with solubility. You know, when you keep on adding salt to water, it keeps dissolving it. At a point, if the solute, that is the salt you're adding, becomes more than the water, you will see that the salt will crystal out. That is just how you will understand this. When there's excess formation of these crystals or urates, the uric acid in the blood, the time will come, it becomes excess that it begins to form crystals. It becomes to form what? Crystals. And these crystals will now be distributed by the body and likely deposited in this joint. Look at this. This is a gout arthritis happening at the big toe of a patient. See how this joint has been destroyed here. And this is the deposition of that crystals. For whatever reason that the body begins to produce excess uric acid, or the kidney is failing, that is not as unable to remove excess, or both. This is now deposited in part of the body. Look at this ankle of this patient. This is a uric hyperuricemia, and it translates to production of urate crystals that are now deposited in the ankle of this patient. This patient will find it difficult to move because this ankle is already facing a lot of induced friction and pain. The patient will facing a lot of pain here and frictions because it has destroyed the that joint, this ankle joint integrity, and this is known as gout arthritis. Now, we have talked about gout arthritis. Remember, we are dealing with two sets of crystal-induced, the gout arthritis and pseudo-gout arthritis. Now, this one is known as pseudo-gout arthritis, and it is caused by calcium pyrophosphate crystals, where the other one is by monosodium crystals. So in pseudo-gout arthritis, calcium pyrophosphate dehydrate crystals can form due to abnormal metabolism or deposition of calcium pyrophosphates, which is associated with conditions such as aging, when someone is getting much older, or the person had a joint trauma, or there is what is known as metabolic derangement, such as in hyperparathyroidism, where the ions of the body are no longer being handled or in a homeostatic form, that one exceeds the other. There is derangement from the normal. as such, can lead to excess formation of calcium pyrophosphate dehydrate crystals. When there's metabolic derangement, such as in hyperparathyroidism, the parathyroid gland is overfunctioning, producing much that is not required and is not being regulated by the feedback mechanism of the body. Then it can lead to the body producing excess of this calcium pyrophosphate, and which can now form crystal and be deposited in the joints. And that's known as pseudo gout. Okay, but for that of the gout, it's a result of uric acid being overproduced, or the kidney not able to remove it from the general body. Whereas this one is as a result of either a joint trauma that triggered an inflammatory response that led to that, or when there's metabolic derangement, like in hyperparathyroidism, or as a result of aging. You know, aging comes with a lot. So that can lead to excess production of the calcium pyrophosphate crystals, which can be deposited and lead to gout arthritis. So if you look at this joint now, this joint is already healthy, but you see these crystals, calcium pyrophosphate deposit from the body. The body carries and start depositing it at the joint. And before you know it, this will destroy this articular surface, and this joint integrity will be compromised, and the patient will begin to face a lot of pains and all of that. Now, that is the first, because we are taking these diseases, both the pseudogout and the gout. The first phase is deposition of these crystals, either as a result of the body overproducing the uric monosodium crystals and depositing it at the joint, or as a result of the body from metabolic derangements, aging leads to formation of calcium pyrophosphate and still deposited at the joint. That's the first stage. Then when these have been deposited at the joint, what's the next thing that happens? That is known as inflammatory response. When these crystals are deposited in both in the synovial fluid, these crystals act as irritant. It irritates the joint. And as it's irritating the joint, the immunity of the body will react, recruit a lot of immune cells, that the body fighters, such as neutrophils and macrophages, to that joint where these crystals have been deposited. And when this is deposited, that leads to the next phase. First phase, the crystals from the body, for whatever reason, like we said earlier, is now deposited at the joint. Second phase is inflammatory response. The body have to fight, because ordinarily, those things are not found in the joint. So if they come there, the joint will be like, what is going on? Who are those people? It will not trigger a response, and the body will send immune fighters. And when the body sends immune fighters, the neutrophils and the macrophages, they will come to attack that crystals. So the process of attacking the crystals leads to phagocytosis, and that's the third phase. So when the neutrophils and macrophages attempt to destroy the crystals, they trigger a lot of cascade of intracellular signal pathways. That is, pathways for fighting, pathways for response, like in a country where there's invaders, or a country is being attacked by another nation, the internal security will trigger to come and kill the invaders. You understand? So the same thing happens to the body. So when the joint family notice this, they send for response, and the body fighters will come to that place to come and fight. So the process of signaling those pathways leads to inflammatory response, and this leads to joint destruction, because the immune bodies are there to destroy whatever that is abnormal, whatever that has been marked to be destroyed. So the process of trying to destroy the crystals, they would attack and destroy the cartilages and synovium and the synovial structures in the joint. And this will now lead to synovial inflammation. And you know, inflammation, like we said, has its character: pain, loss of function, rubor, color, heat, and all of that. Redness, pain, loss of function, and all of that will begin. The patient begin to feel all of this, and this attack by the immune cells of the body leads to destruction of the joint smooth tissue, smooth surface we already know, and that will lead to joint damage. So as the crystals are also may cause mechanical damage to the tissue and act as a wear particle at the joint surface. You know, a particular surface that is already smooth This is smooth. Now, look at this. Let's go back to that. Now, this is smooth already, very smooth and moving comfortably. All of a sudden, a crystal like a stones are now deposited here. What will happen? It will lead to destruction of these smooth surfaces. And that's what we mean by mechanical damage. It leads to mechanical damage of that what surface. And when that happens, the joint is already destroyed. So as they cause wear and tear that surfaces, it can lead to a serious inflammation. And once there's inflammation, there will be destruction of that joint. Now, it's also worthy of note to know that the gout, we are done with the pathophysiology. What happens? The position of the crystal salt, crystal stones, then the response by immune cells, and then the destruction, the inflammation. Now let's look at gout again. Gout is the most common inflammatory arthritis in men and in older women. It is caused by deposition of the monosodium urate monohydrate crystals around the synovial joints. About 1/10 of the body uric acid pool is derived from dietary sources. One will be wondering, how do the body get this uric that the body is unable to eliminate in excess of it or overproducing it? And findings have shown that 1/10 of the body uric acid pool is being derived from what we eat. Then 2/3 of it is from endogenous purine metabolism, that the metabolism of purines in the body leads to the production of uric acid. Then 1/3 of what we eat has uric acid. So the concentration of uric acid in the body fluid depends on the balance between the endogenous synthesis, that is the production of this uric acid for purine metabolism, and the elimination by the kidneys. So that is what I'm trying to say. So for someone to have a gout from monosodium urate monohydrate crystals, one, it must have come from what the person has been eating. Two, it must have come that the body production of this uric acid from purine metabolism, and the ability of the kidney to eliminate those ones the body has produced and the one we are eating. If the one we are eating is bringing in uric acid and the one the body is producing is bringing uric acid, and the kidney is unable to eliminate all of this, the uric acid formation of the crystals will occur. It's also worth of note for us to know that the following drugs as well can lead to reduced excretion of uric acid. So in certain conditions, like patients who are hypertensive, who are taking thiazides and loop diuretics, there are a group of drugs that used to control fluid and directly work on the renin-angiotensin and other mechanisms responsible for regulation of blood pressure. As they're taking these drugs, it leads to reduce the ability of the kidney to excrete uric acid. The drugs are thiazide and loop diuretics, low dose aspirin, cyclosporine, and pyrazinamide for patients taking on TB drugs. This pyrazinamide is a TB drugs. So patients who are tuberculosis patients and who are taking this pyrazinamide might likely have reduced clearance of uric acid from their body and might likely have this gout arthritis. So what are the other things that contribute? Because we said that it's for you to have a gout arthritis as a result of monosodium urate monohydrate crystals, the person must have been consuming foods and the body is producing a lot of uric acid from the purine, and the kidney is unable to remove all of this. So we've talked about the how drugs contribute to that reduced kidney clearance, that is reducing the ability of the kidney to clear uric acid from the body. And now we're looking at what are the things we are likely to consume that would lead to increase in production of uric acid. One, alcohol. Alcohol is a key. Two, foods that are high in offals. That's what offal. Then seafoods, red meats, red meat, then fructose, and also foods that are low in vitamin C increases uric acid in the body. So that's how the body is able to get excess of this. Crystals may be deposited in the joints and soft tissues, like you're seeing here, to produce irregular firm nodules. And this is the nodules. And this nodule you are seeing here is called the toffee. This is called the what? The toffee. In some patients, you might see it at the ear. That's crystals, either of monosodium or calcium pyrophosphate, which could either say this is pseudo gut or gut itself. So you see it being deposited there. And this is called a toffee. These have a predilection for the external surfaces of the fingers. You can also find the fingers of the patient depositing in the fingers of the patient, the joint fingers of the patient, the interphalangeal joints. You see, then another is the hands, forearms, elbows. You can also find it at hands, forearms, and elbows. Then you can also find this also deposited at the Achilles tendons. This is called the Achilles tendon. This tendon that connects the leg and the foot is known as the Achilles tendons. And sometimes you can find these crystals deposited at the back of the ear. You might also see that being deposited. So that's where the gut crystals can be found. Also, the other crystals can also be found deposited in those areas. Here is deposited in this big toe. This person cannot walk because this will definitely destroy the joint movement here. Clinical presentation. Now let's look at the clinical presentation. If you look at this patient's hand, you see the crystals being deposited here. That's why we say it can be found at the ear, the interphalangeal joint. This is called the interphalangeal joints and the ear. The classical presentation of this condition is an acute monoarthritis. That's how you can clinically diagnose pseudogout or gout. It only affects one joint at a time. And mostly, the first joint it affects the metatarsal phalangeal joint in 50% of the cases. Metatarsal phalangeal joint. Other common sites you can find this is the ankle, like we saw earlier, the midfoot, the knee, small joints of the hands, wrist, and the elbow. You can find them at the elbow. You can also find at the wrist here. You can also find it at the knee and foot. But most commonly, metatarsal phalanges are on the foot. That's the big toe. Big toe of the foot is the common site. You find this 50% of it. The big toe. That's the major place you find this big toe. This is where you find it. Mostly 50% of the cases occur here. That's where the 50% of the condition do occur. Then it can also be found in other places like elbow and all of that. It can also be found there. So that is what happens. Other typical, the exoskeleton and large proximal joints are rarely involved. So that is the spine and the hips may not be in. Rarely would you find pseudogout or the guts in affecting the hip joint and that of the skeletal joint. What are typical features of this condition? It is rapid. It can reach maximum severity in 2 to 6 hours and often wakes the patient in the early morning with severe pain, often described by the patient as the worst pain ever. That is, the pain is an excruciating one. Just imagine where a stone is in your body, in a joint that moves. It's going to be much excruciating. Now, patients with crystal-induced arthritis typically experience acute episodes of joint inflammation characterized by sudden onset. There is of sudden, often occurring at night. The pain can be excruciating and often affects unilateral joints. Well, what we mean by unilateral, one particular joint at a time. With the metatarsal phalangeal joints, that is the great toe, the big toe, being particularly susceptible to gout. That's the most common. Then, once it affects that joint, it leads to swelling and erythema. Erythema is redness. and swelling. The affected joints may appear very swollen, red, and warm to touch due to the increased vascular permeability and fluid influx due to the inflammation. If you look at here, look at this big toe, and I see that it's reddened, inflamed. Look at the shape of the joint is already distorted. The shape of the joint is distorted. It is painful. It is reddened. So these are the clinical signs of gout arthritis. Then the patient may present with fever, malaise in acute case due to the inflammation. The chronic gout can lead to the formation of tophi, like we said, which are aggregates of Uric crystals that can develop in soft tissues, like soft tissues of the ear, on the elbow, on the skin too. And could lead to chronic joint deformity and damage. Whereas insidious gout, it can also cause cartilage degeneration and osteoarthritis changes in the affected joint. So insidious joints can lead to osteoarthritis changes. You know, osteoarthritis is about degeneration of the articular surface due to it's mainly genetic that leads to the destruction of the articular surfaces. And that articular destruction in osteoarthritis is due to gene forming a cartilage that is of low quality, or that is defective, or that lacks a very strong matrix due to depletion of one important component or the other. That makes the cartilage to be unable to do the work. But here, the cartilage is normal, the surface is normal, just that introduction of a crystal into it, unlike in the osteoarthritis. Diagnosis and management. Diagnosis of crystal-induced arthritis usually involves joint aspiration, known as arteriocentesis. So here, the synovial fluid is taken to the lab, and the crystals are now analyzed using the polarized light microscopy and all of that. Then also, some cell tests can also be run, so as serum uric acid levels. This can be measured to determine the gout and all of that, to check for hyperuricemia. Management of this condition is through the use of non-steroidal anti-inflammatory drugs to reduce pain and inflammation during acute attacks. The same objectives for management in osteoarthritis, like relief pain, restore joint integrity, enhance joint movement, reduce inflammation, and all of that is still the key here. Well, you're going to avoid pain because the patient is having excruciating pain. Then the drugs you also give can help abort the acute attack. These particular drugs, then corticosteroids used for severe flares and in cases where NSAIDs are contraindicated the patient, like a patient who has who has ulcer, may not be given. Then a patient too who has a reduced renal clearance ability may not require that drug, because these drugs have effect on the nephron. Then the patient needs what's called lifestyle modification, such as dietary changes. The person needs to be taking enough water. Hydration is the key. Taking enough water. Then weight management, so that help control uric acid levels and reduce flare frequencies. When the person's weight should be regulated. Then what the person eats too. Since we've known alcohol, most seafood, and all of that contribute to high uricemia, then our patient needs to really modify what the person eats, so that to reduce the chances of having hyperuricemia. Then oral prednisolone can also be given in the management. So, but for our primary healthcare workers in Nigeria, you are required to utilize the national guidelines, the national standing orders in management of these conditions. But these drugs are for you to understand the drugs that can be used in management of these conditions. And the standing orders, these drugs are also written that you use them based on the dosage that is recommended nationwide. So that is all about crystal-induced arthritis among patients, and how they present, the two types of it, gout arthritis and pseudo gout arthritis. So we'll be able to look at that in this section. In the next section, we'll be looking at rheumatoid arthritis. I hope you would also join that section. Thank you very much.